Hello.
Yes, sir. The screen
Am I
is.
audible? Am I audible?
Yes,
मेरी आवाज
sir.
आ रही है?
Yes, sir.
Should we start this class?
Yes, sir.
Okay. Very good afternoon. Today we will discuss about the shoulder joint special test because it is a part of the syllabus. We have to go through the assessment and evaluation of the all orthopedic conditions. Basically, we will cover joint by we'll start from upper limb, then lower limb, then spine.
Okay, sir.
Firstly, shoulder joint special test. Under this special test, firstly we'll discuss about the anterior instability of the shoulder joint. Under this test, under this problem, we'll discuss about the three tests: load and shift test, Roku test, anterior door test. And the second condition will be posterior instability of the shoulder. And this condition will be covered by the load and shift tests, posterior apprehension test, and Noru test. Third is inferior instability test. We'll cover it by sulcus sign and the aging test. Then the next will be the impingement test, shoulder impingement test. Under this condition, we'll discuss about the near test, Hawkins in test, posterior internal impingement test. Then labral lesion. Under labral lesion, we'll discuss about the clung test, anterior slide test, active compression test, biceps tendon test, slap. Then we'll discuss about the shoulder stability test, scapular stability test, lateral scapular slide test, wall, floor, push-up test, scapular retraction test. So these are the tests we'll discuss one by one. First is anterior instability test. We'll discuss. See, all these tests all these are the tests of the joint, shoulder joint test. Now the next test will be the muscle tendon pathology test. Muscle tendon pathology test, under this we'll discuss about the speed test, elongation test, empty cane test, lift off sign, leg or a spring back test, trapezius weakness, serratus anterior weakness, and pectoralis major and minor tightness. Then we'll discuss about the neurological involvement. Under this condition, we'll discuss about the upper limb tension test, ULTT. Then thoracic outlet syndrome. This syndrome will be assessed by the Rouge test. Then the first test is the test for anterior shoulder instability test. The shoulder joint is complex joint and it is composed of glenohumeral joint, then acromioclavicular, then scapulothoracic. Here we will discuss about the glenohumeral instability. And first we will discuss about the anterior shoulder instability test. This test is done by load and shift test in sitting position. See, patient is in sitting position. You can see the this anatomical structure of the shoulder joint. Glenohumeral composition. This is the clavicle, acromioclavicular joint. Basically, we test here at the glenohumeral area, and this test is known as load and shift test. How will do this test? To check primarily for traumatic instability problem of the glenohumeral joint. Patient will be sit with no back support, with the hand of the test arm rest on the thigh in a ideal aligned posture with the shoulder muscle fully relaxed. Examiner will be stand behind or sit behind the patient and stabilize the shoulder with one hand over the clavicle and the scapula. And with the other hand, examiner grasp the head of humerus with the thumb. See, this will be the test position. Examiner other hand will grasp the head of the humerus with the thumb over the posterior humeral head and the fingers over the anterior humeral head and check whether it is properly seated in the glenoid fossa or not. This is the load portion of the test. If the load is not applied, there is no normal or standard starting position for the test. Examiner then push the humeral head anteriorly for anterior instability and posteriorly for the posterior instability, noting the amount of rotation and the end field. This is the shift portion of the test. Normal and affected sites are compared, and the reproduction of the patient's symptoms is often considered more important than the amount of movement obtained. Here the patient will tell, yes, I am feeling pain while you are shifting the shoulder anterior, head of humerus anterior or posterior. Translation of 25% or less of the humeral head's diameter anteriorly is considered normal, although results vary among patients. Generally, anterior translation is less than the posterior translation. For posterior translation of the 50% of diameter of the humeral head is considered normal. See, can anyone tell which dislocation is more common in the shoulder joint, whether it is anterior or posterior? Hello?
Sir.
Can you tell which dislocation is very common in shoulder joint, whether it is anterior dislocation or posterior dislocation?
I think anterior dislocation.
Yes, anterior dislocation is very common.
More unstable
And
there.
in joint, posterior dislocation is very common.
Common.
So this test is for the assessment of the anterior dislocation of the shoulder joint. Rates of anterior glenohumeral translation. Normal laxity is around 25%. For grade 1 type of dislocation, the shifting should be 25 to 50%. A feeling of humeral head riding up to glenoid rim. For grade 2, feeling of humeral head over riding the rim but spontaneously reduced is greater than 50%. For grade 3, the feeling of humeral head over riding the arm but remains dislocated. Around translation is again around 50%. These are the three grades of the anterior dislocation of the glenohumeral joint. Now, second test is Rockwood test. Rock test for the anterior stability. Arm at the side, arm at 45 degree. Examiner stand behind the seated patient with the arm at the patient side. The examiner laterally rotates the shoulder. See, examiner has laterally rotated the shoulder. The arm is abducted to 45 degree. Arm is first laterally rotated, then abducted to 45 degree, and the passive lateral rotation is repeated. The same procedure is repeated at 90 degree and 120 degree. The different positions are performed because the stabilizers of the shoulder vary as the angle of the abduction changes. For this test to be positive, patient must show marked apprehension with posterior pain when the arm is abducted to 90 degree. At 45 and 120 degree, the patient show some uneasiness and some pain. At 0 degree, there is rarely apprehension. That is why we say the most open pack position of the shoulder is abduction and lateral rotation, because in this position there is a chance of the anterior dislocation of the shoulder. That is why Rockland test is done in this position, abduction and lateral rotation. Now see, arm at 45 degree of abduction, at 90 degree of abduction, and at 120 degree of abduction. Is along with abduction, examiner has to do externally rotate the shoulder. And during this maneuver, patient will feel pain. This is the sign of anterior dislocation. This is known as raw foot test. Third is anterior drawer test. Anterior drawer test. The patient lies supine. Examiner places the hand of the affected shoulder in the examiner's axilla. See, this is the position of the patient and therapist for performing anterior drawer test for the shoulder. The examiner lies supine. The examiner places the hand of the affected shoulder in the examiner's axilla. Examiner places the hand of the affected shoulder in the examiner's axilla, holding the patient hand with the arm so that the patient remains relaxed. The shoulder to be tested is abducted between 80 to 120 degree, forward flexed up to 20 degree, and laterally rotated up to 30 degree. So here abduction is between the 80 and 120, forward flexed up to 20 degree, and laterally rotated up to 30 degree. In this position, then the examiner stabilizes the patient scapula with the opposite hand, pushing the supine of the scapula forward with the index of the middle finger. Then what will happen? Examiner's thumb exerts counter pressure on the patient for a quiet process. Using the arm that is holding the patient hands, the examiner places his hand around the patient relaxed upper arm and draws the humerus forward. See, this test is a little bit difficult. But the more common tests are these two tests. What we have talked earlier. First was the load test, and second was the raw foot test. It is very easy to do. Now the test for posterior shoulder instability. Again for this test, load and shift test as discussed earlier, posteriorly. See the patient position will be in sitting position. Patient will be seated on a table or chair without any back support. Therapist will stand posteriorly, and from one hand, therapist will stabilize the clavicle and the scapula. The other hand will grasp the head of the humerus and push it posteriorly. This will be known as the posterior dot test. Sorry, posterior load and shift test. Posterior load and shift test. Not dot test. Posterior load and shift test. Now the second test for the posterior dislocation or for the assessment of posterior dislocation of the shoulder is posterior apprehension test or stress test. Posterior apprehension or the stress test. The patient is in supine lying position or in sitting position. The examiners elevate the patient's shoulder in the plane of the scapula to 90 degree while stabilizing the scapula with the other hand. The examiner then applies a posterior force on the patient's elbow. While applying the axial load, the examiner horizontally adduct and medially rotate the arm. First, the examiner will apply posterior force on the patient's elbow. ठीक है? Then, while applying the axial load, the examiner horizontally adducts and medially rotates the arm. The positive result is indicated by a look of apprehension or alarm on the patient face and the patient's resistance to further motion or the reproduction of the patient's symptoms. This test will be known as posterior apprehension test or the stress test. And this test either we can do in supine position or in sitting position, sitting with medially rotated and adducted shoulder. Our test is Norwood stress test. The patient lies supine with the shoulder abducted to 60 degree to 100 degree. Then laterally rotates, rotated up to 90 degree and elbow should be flexed to 90 degree. Then arm is horizontal. Here the patient lies supine with the shoulder abducted 60 to 100 degree, laterally rotated 90 degree and elbow should be flexed to 90 degree, arm is horizontal. The examiner stabilizes the scapula with one hand while patting the posterior humeral head with the finger and stabilize the upper limb by holding the forearm and elbow at the elbow or wrist. At the same time, examiner feels the humeral head slides posteriorly with the finger. The thumb may push the humeral head posteriorly as the horizontal adduction in the forward flexion is carried out to enhance the effect. Positive test is indicated if the humeral head slips posteriorly related to the glenoid fossa. This test will be known as Norwood stress test. You can go through the Maggie orthopedic assessment book. In that book, all procedures are mentioned. Now, test for inferior and multidirectional shoulder instability. See, inferior instability is very rare condition. For this condition, we will do sulcus sign. Patient stands with the arm by the side and the shoulder must relaxed. The examiner grasps the patient's forearm below the elbow and pull the arm distally. The presence of sulcus sign. Sulcus sign means you will see there will be depression here over the glenohumeral area. The presence of sulcus sign may be the feeling of subluxation, may indicate inferior instability of the glenohumeral or the glenohumeral laxity. Sulcus sign grading: +1 distance less than 1 centimeter. For +2 sign distance should be 1 to 2 centimeter. For 3+ sign it should be more than 2 centimeter. So this sulcus sign shows shoulder instability, or you can say inferior dislocation of the shoulder. See, posterior sulcus sign is there. Physiogeny sign. Physiogeny test. It is modified sulcus test. Sign test. Sorry. Patient will be in sitting position. Examiner hold the patient's arm at the elbow. At the elbow, and elbow should be extended in extended position. And arm should be abducted to 90 degree with one hand, and the arm holding the arm against the examiner's body. Examiner hold the patient's arm at the elbow, extended and shoulder 90 degree abducted, okay, and the arm holding in the forearm will be holding in the patient's against the examiner's body. The other hand will be placed just lateral to the acromion over the humeral head. Shoulder musculature relaxed. Examiner pushes the head of the humerus downwards and forward. Downward and forward. Sulcus is seen above the quiet process. Look of apprehension, presence of anterior inferior instability shows positive test or the inferior dislocation. See, this type of test, meaning of test is to glide the head of humerus inferiorly and anteriorly. Now, common test for shoulder impingement. See, what is impingement? Impingement क्या होता है, कोई बता सकता है? Impingement is basically when between two bony structures there is some space and some soft tissue structures are present. If that space is reduced, the soft tissue structure become compressed and compromised. That condition is known as impingement. So the impingement में क्या होता है, जो कोराकोएक्रोमियल जो आर्च होता है उसके बीच में जो सॉफ्ट टिश्यू स्ट्रक्चर्स होते हैं, टेंडन्स होते हैं, वो कंप्रेस हो जाते हैं और उसके चलते क्या होता है, उसमें टियर हो जाती है. That is known as impingement test. The patient arm is passively and forcefully fully elevated in scapular plane with the arm medially rotated by the examiner. Means arm should be medially rotated and it will be elevated in a scapular plane. The passive stress causes the greater tuberosity of the humerus to jam against the anterior inferior border of the acromion. तो क्या होगा यहाँ पे ग्रेटर ट्यूबरसिटी और एक्रोमियल प्रोसेस के बीच का स्पेस कम हो जाएगा and because of that thing what will happen the supraspinatus muscles tendon basically uh, originated from that place that area and that is why there is chance of the injury of the supraspinatus tendon and also sometimes the biceps tendon and this may cause the supraspinatus tendinitis or basilar tendinitis coracoacromial acromioclavicular differentiation test. If test is positive, then done with the arm laterally rotated. Okay. For acromioclavicular uh, joint impingement, we should do the same test with arm laterally rotated. The examiner should check the acromioclavicular joint. This test will be known as near impingement test. See, this is the acromial process of the scapula and this is the clavicle and this is the joint acromioclavicular joint acromial process acromioclavicular joint
So you are not audible.
coracoacromial ligament and coracoid process the test may also
Sir,
yes
you got disconnected and so your screen is not visible.
I'm disconnected
Yes, sir, you were disconnected in between. You've just joined in.
now is it okay
Sir, we can see you, but we cannot see any screen. We cannot
the
see the
screen is not
presentation.
there
No, sir, the presentation is not there.
okay this is not there from how many
So
period
just 1 minute it has happened.
let me check it now is it okay
No, sir, nothing is being shared.
entire screen
Now, sir, your screen is sharing.
Okay. Is it okay?
Yes, sir. Now it is fine.
Okay. Hawkins Kennedy test. See this in this test, the patient will stand while the examiner will flex the shoulder at 90 degree and then forcefully medially rotate the shoulder. This maneuver, what will happen again? The space between the uh, you can say acromion process and the greater tuberosity will decrease, and this tendon, supraspinatus tendon will be get I can say compressed, and the anterior surface of the coracoacromial ligaments okay. This space will basically reduce in this case, and again the patient will feel pain because of the compression over the supraspinatus tendon. This test indicate the supraspinatus tendinitis because of the impingement. And this is the posterior internal impingement test. This type of impingement is found primarily in overhead athletes or other who hold their arm in vulnerable position. The impingement occurs when the rotator cuff impinges against the posterior superior edge of the glenoid, when the arm is abducted, extended, and laterally rotated. Arm is abducted, extended, and laterally rotated. This position. The result is of kissing labral lesion posteriorly. The result impingement is between the rotator cuff and the greater tuberosity on one hand, and the posterior glenoid and the labrum on the other hand. It often accompanies anterior instability, and the deltoid activity increases to compensate weakened rotator cuff. This is the posterior area of the posterior internal impingement. Area of posterior internal impingement. This is the area. Acromion process. Greater tuberosity. Rotator cuff tendons are here. Superior labrum. Posterior superior edge of the glenoid cavity. Test for labral tear. What is labrum? Labrum को कोई बताएगा? What is labrum? Labrum is the fibrocartilaginous structure present within the glenoid cavity, and it basically it's because of the presence of labrum, the glenoid cavity acts as a socket. It holds the ball of the Hello.
Yes, sir.
Actually, because of the network problem, this thing happened.
Yes, sir.
Now is it okay?
Yes, sir. Your screen is sharing.
Okay. Good. Lateral test. Yes, we are discussing about the test for lateral tear. Lateral के बारे में हम लोग बात कर रहे थे ना?
हाँ जी, sir.
Lateral tear common in throwing athletes. In young, tensile strength of the labrum is less than the capsule. In young, the tensile strength of the labrum is less than the capsule. Tear may be Bangkok lesion in which the anterior inferior labrum is torn or slap that is superior labrum anterior posterior to the biceps lesion. See, these two types of the lesion in labrum is common. Bangkok lesion in which anterior and superior labrum is torn, and second is superior labrum anterior and posterior to the biceps, that is known as slap. Type of slap lesion, it is four types. Superior labrum marked frayed but attachment is intact.
हाँ जी.
Type 2, superior labrum less has a small tear and there is instability of the labral biceps complex. Type 3 is bucket handle tear of the labrum that may displace into the joint, labral biceps attachment intact. Type 4 is bucket handle tear of the labrum that extends to biceps tendon, allowing tendon to sublux into the joint. So these are the four types of the labral tear. Test for confirming the labral tear. First is the Clunk test. So labrum is the fibrocartilaginous structures found within the glenoid cavity, and it's because of the fibrocartilaginous structure property, it can create more depth in the cavity and it holds the head of humerus. And because of its tear, the head of humerus doesn't fit properly in the cavity, glenoid cavity. The first test is Clunk test. Patient will be lie in a supine position. Examiner place one hand on the posterior aspect of the shoulder, aspect of the shoulder over the humeral heads. Other hand holds the humerus above the elbow. Examiner fully abduct the arm over the patient's head and then pushes anteriorly with the hand over the humeral head, while the other hand rotates the humerus into the in lateral rotation position. A clunk or grinding sound indicates positive test for the tear of the labrum. This test causes apprehension and resistivity is present. Means this test indicates that there is more, like you can say, a space between between the head of the humerus and the glenoid area, and it's also indicate the instability of the glenohumeral joints. Second is anterior slide test. Patient is sitting with the hand on the waist. The examiner stands behind the patient and stabilizes the scapula and the clavicle with one hand. And with the other hand, the examiner applies an anterior-superior force at the elbow. If the labrum is torn, the humeral head slides over the labrum with the pop or crack, and the patient complains of anterior-superior pain. This is anterior slide test. Third is Active compression test. For the slab, the patient is placed in standing position. See, this is the position. Position 1 and 2nd. Patient is instructed to stand in a standing position with the arm forward flexed to 90 degree and the elbow fully extended. The arm is then horizontally adducted at 10 to 15 degree starting position and medially rotated so the thumb faces downward. See this, sorry, this is the position. The examiner stands behind the patient and applies a downward eccentric force to the arm. The arm is turned to the starting position and the palm is supinated and the downward eccentric load is repeated. If the pain or painful clicking is produced inside the shoulder in the first part of the test and eliminated or decreased in the second part, the test is considered positive for superior labrum anterior posterior lesion. These are the two positions, position first and second. The next is biceps tension test. This test determines whether the superior labrum anterior posterior lesion is present. The patient is standing. Patient will be in a standing position. Abducted and laterally rotated the shoulder at 90 degree with the elbow extended and the forearm supinated. The examiner then applies an eccentric adduction force to the arm. Reproduction of symptoms shows positive test. Test for scapular stability. Seek scapular sign and symptom. Insidious onset is insidious means gradual. Prominence of inferior medial border of the scapula. Protraction of the scapula. Acromion less prominent, required very tender to palpation. Tight pectoralis minor muscles. Leg full forward flexion and tight short head of biceps. This scapular stability test is done by the lateral scapular stride test. This test determines the stability of the scapula during glenohumeral movement. Patient sit or stand. Patient sit or stand with the arm resting at the side. The examiner measures the distance between the base of the spine of the scapula to the spinous process of T2 or T3 from the inferior angle of the scapula. arm length from the wall. And he can do wall push-up 15 to 20 times. Any weakness of the scapular muscles or winging usually shows up to 5 to 10 push-ups. This is known as wall or floor push-up test. Winging of a scapula is basically occurs by weakness of which muscles? Can anyone tell? Winging of a scapula is basically occurs by the weakness of which muscles? Hello?
So it is more of subscapularis.
Serratus anterior.
Yes, sorry, sir. Serratus.
Serratus anterior, because it causes the पुशिंग एंड पंचिंग मोमेंट, वो जो एक्शन खत्म हो जाता है, और इसी से स्केपुला जो विंगिंग हो जाती है बेसिकली पीछे की तरफ ज़्यादा प्रोमिनेंट हो जाती है. तो दीज आर दी टू टेस्ट. A scapular retraction test also we can do. Patient is in a standing position. Examiner stands behind the patient, places the fingers of one hand over the clavicle, with the heel of the other hand over the spine of the scapula to stabilize the clavicle and scapula, and hold the scapula retracted. Examiner's other hand compress the scapula against the chest wall. Holding the scapula in this position provides a stable base for the rotator cuff muscles, so its strength improves. If a scapular retraction decreases the pain when the relocation test is performed, it indicates that weak scapular stabilizer are present. Scapular retraction test. Test for tendon injury or tendon pathology, tendon or muscles pathology. A speed test for the biceps tendonitis, bicipital tendonitis, you can say. The examiner assists shoulder forward flexion by the patients while the patient forearm is first supinated, then pronated, then elbow extended. The test may also be done by forward flexing the patient's arm to 90 degrees and then asking the patient to resist an eccentric movement into extension first with the arm supinated, then pronated. This is known as a speed test. These tests shows bicipital tendonitis in the bicipital groove with the arm supinated. See, when the forearm is supinated and someone is doing flexion, this is done by the biceps muscles. When the forearm is mid-prone position, this flexion will be done by the which muscles? See, there are three types of elbow flexion. Elbow in flexion in forearm supinated position, elbow flexion in forearm mid-prone position, and elbow flexion we can do in forearm pronated positions. In three positions, three muscles involved to perform this movement. The in supinated position, biceps basically act. That is why in supinated position, if this test is positive, it indicates there is bicipital tendonitis. Yergosson test to check the ability of the transverse humeral ligament to hold the biceps tendons in the bicipital grooves. Patient elbow flexed to 90 degrees and stabilize against the thorax. Patient elbow flex to 90 degree and stabilize against the thorax with the forearm pronated. Examiner assists supination while the patient also laterally rotates the arm against resistance. If the examiner palpates the biceps tendon in the bicipital groove during the supination and lateral rotation moment, the tendon will be held to pop out of the groove if the transverse humeral ligament is torn. Tenderness in the bicipital groove alone without the dislocation may indicate bicipital tendonitis. Supraspinatus tendonitis tests. It is very common test we use in our clinical setup while we treat the shoulder arm or like shoulder pain. Patient arm is abducted to 90 degree with no rotation. An examiner provides assistance to abduction. The shoulder is then medially rotated and angled forward 30 degree. So the patient hands point towards the floor in the plane of scapula. Resistance to abduction. Resistance to abduction is given again while the examiners look for weakness or pain, giving positive results which indicates the tear of supraspinatus tendon. सुपरस्पिनेटस मसल्स का मेन फंक्शन क्या है? एब्डक्शन है. मींस अगर आप एब्डक्शन को रेसिस्ट करोगे तो पेन होगा. See, tendonitis, the main test for assessing tendonitis in a tendon injury is just to do resistance test. Bicipital tendonitis हुई है, biceps muscle injury है, resisted elbow flexion कराओ, patient pain feel करेगा. Supinated position, that means biceps tendon में कहीं ना कहीं injury है. Again, supraspinatus is the main function of supraspinatus muscle is to perform abduction of the shoulder. Assisted abduction आप कराओगे, patient will feel pain. This shows the injury of supraspinatus tendon. Lift off sign. Lots of tests are there. Lateral rotation, leg sign. Lateral rotation, leg sign. Drop sign. Drop sign में क्या करते हैं? Patient is in a standing position and the arm is abducted to 90 degree and the elbow is flexed to 90 degree. Examiner maximally externally rotate the arm and patient is asked to hold this position. If the arm falls or drop into medial rotation, test is positive for infraspinatus and supraspinatus tear and maybe subscapularis tear. So this is again the test for rotator cuff injury. Trapezius weakness test. Patient sits down and place the hands together over the head. Examiner sits behind the patient and pushes the elbow forward. Patient sits down and places the hand together over the head. Examiner sits behind the patient and pushes the elbow forward. Okay. Test for upper trapezius. For the whole trapezius. For upper trapezius, elevate the shoulder with the arm slightly abducted or assist shoulder abduction and head side flexion. This is second one is the test for upper trapezius. This is test for the whole trapezius. For the middle trapezius, patient in prone position, arm at 90 degree of abduction, and elbow is also in flex position and lateral rotation of the shoulder. Examiner assists horizontal extension of the arm, watching for retraction of the scapula, which should normally occur. If protection of the scapula occurs, middle fiber of trapezius are weak. These are the three positions or the weakness to test the trapezius weakness test. For the lower trapezius, patient is in again prone position, lying. Arm is abducted to 120 degree, shoulder is in lateral rotation. See, his arm is 120 degree abducted, shoulder in lateral rotation position. Examiner applies resistance to the diagonal extension and watches a scapular retraction that should normally occurs. If a scapular protection occurs, lower trapezius are weak. If a scapula is elevated more than normal, tight trapezius or cervical torticollis may be present. Saddle weakness, again, it is very simple test. Patient is in a standing position, arm is forward flexed to 90 degree. Examiner applies a backward force to the arm. If the medial border of the scapula wings, this shows weakness of serratus anterior. You can also test rhomboid muscle, these are the small muscles. You can also test pectoralis major contraction muscle. Pectoralis minor test. Test for neurological sign upper limb tension test. एक थोड़ा सा important test है. Upper limb tension test. Brachioplexus tension से create होती है. Patient is in supine position to stress the neurological tissue entering the arm. Test begins by testing the good arm first, positioning of the shoulder, then forearm, then wrist, finger, last elbow, side flexion or cervical spine. Side flexion of cervical spine. So eval TT1, eval TT2, upper limb tension test 1 and upper limb tension test 2. Its test is contraindicated in case of worsening neurological sign. neurological sign बहुत ज़्यादा है, क्रोनिक केस में इसको अवॉइड करते हैं. Then also in acute phase, pain level is very high. In case of cauda equina, where there is cord injury symptoms, spinal cord injury lesions are there, we should avoid this test. ULTT 1 and 2 positioning will be shoulder in depression and abduction of the 110 degree. Elbow will be in extended position. Forearm supinated, wrist extended, finger and thumb extended. Cervical spine flex contralateral sides. This indicates the you can say compression or injury of the median nerves, anterior inflorescence nerve, and the C5, C6, C7 area is mostly affected in this case. ULTT2 position will be depression and abduction of the shoulder by 10 degree. ULTT2, this one was the first, this is the second. Extension of the elbow, supination of the forearm, extension of wrist, fingers, shoulder laterally rotated, contractor side flexion. It shows again medial nerve injury with musculocutaneous nerve and axillary nerve involvement. ULTT 3 and 4. For ULTT 3, position will be supine position. Shoulder is abducted to 10 degree, elbow extended, forearm pronated, wrist flexed or deviated, finger and thumb will be flexed, shoulder will be in medial rotation, cervical spine will be flexed, contralateral side, and nerve. This will be the test for the radial nerve injury. 24 for the depression. Sorry, in this case, the position of patient will be in sitting position. Abduction of the arm at 10 to 90 degree, flexion of the arm, forearm supinated, extension and radial elevation of the wrist, thumb will be extended, finger will be extended position, shoulder will be in lateral rotation position, and cervical spine will be in contralateral side flexion position. This test will be done for the confirmation of the ulnar nerve injury. थोरेसिक आउटलेट सिंड्रोम के लिए रूज टेस्ट करते हैं. इसका इनकी पोजीशन है. पोजीशन क्या है? शोल्डर विल बी अबडक्टेड टू 90 डिग्री, elbow will be flexed to 90 degree, and tell patient to make the fist and open the fist. What will happen? The patient then slowly open and close the hand for 3 minutes. If the patient is unable to keep hands in this position for 3 minutes and suffers ischemic pain, heaviness, or profound weakness of arm or numbness or tingling of the hand during these 3 minutes, test will be positive. Those test will be positive. और इसको हम कब टेस्ट करते हैं? थोरेसिक आउटलेट सिंड्रोम में. उसमें क्या होता है कि जो ब्रेकियल प्लेक्सिस ये जो कंटेंट होते हैं वो कंप्रेस हो जाता है डिप्रेशन ऑफ बिकॉज ऑफ द टाइटनेस ऑफ द डिप्रेसर्स मसल्स ऑफ द shoulder. Now any question? Hello, Dr. Hina, and second one क्या नाम?
Yes sir, no questions from my side.
Okay, नहीं जो second student का नाम क्या? मैं नाम भूल गया. क्या है नाम उनका? जो
Sir, Dr. Apurva.
क्या?
Dr. Apurva.
Dr. Apurva, sorry. हाँ, Dr. Apurva. Is it okay?
Yes sir.
Sorry, because of the technology problem, I was not able to conduct the classes regularly. We basically faced several times of interruption because of network problem. Now the third class will conduct. कल करना है क्या? तीसरा क्लास कब है?
Sir, I guess Monday को होगी. Next Monday.
Next Monday, okay. चलो मुझे बता दो. Next Monday means date will be Monday 7th, ना?
Yes sir.
7th.
Yes sir.
ठीक है. 7th को we discuss about the knee joint special test and the spine. ठीक है?
Okay, sir.
Okay, then we can discuss the like any problem in that class also. Okay, then bye bye.
Okay sir.
Okay, sir.